Good afternoon. My name is Michelle Brunson. I am a Health IT Advisor with Telegen for the Small, Underserved, and Rural Support Quality Payment Program Resource Center. Presenting with me today is my colleague and friend, Sandy Swallow, a Program Specialist with the Quinn QIO. Sandy works with groups of 16 or more clinicians and larger health system ACOs. Thank you for joining us today to learn how to survive and thrive in the Advancing Care Information category for the Quality Payment Program, also known as MACRA. We hope you discover some tips to take away today that might make your navigation a bit easier. Before we dive deeper into the Advancing Care Information category, I'll first provide some Quality Payment Program updates. Then I will talk more specifically about the scoring, reporting, reweighting, and the objectives for the Advancing Care Information category. Sandy will follow by talking more in depth about the Advancing Care Information scoring methodology, providing examples, and finally we'll provide some tips to maximize your score. We will also provide some links for some nice resources to help you with the understanding of the Quality Payment Program ACI category. The three legacy programs, PQRS, Value-Based Payment Modifier, and Medicare EHR Incentive Program, also known as Meaningful Use, are being reblended into just one program, the Quality Payment Program, or QPP. These three legacy programs' reporting year for their last year was last year, in 2016, and those last payment adjustments as a result are applied in 2018. It takes 2 years after the performance year for the payment adjustments to occur. The Quality Payment Program starts this year in 2017, and it has two tracks, a Merit-Based Incentive Payment System, or MIPS track, and the Advanced Alternative Payment Model, or APM track. You'll report your data anytime from January 1st of 2018 to March 31st of 2018. And the payment adjustments for the Quality Payment Program 2017 year will be applied in 2019, again 2 years after the performance year. Today's webinar will not provide the Quality Payment Program background and basics as you may have been used to. If you haven't heard some of those introductory webinars from CMS or other organizations, you may want to use the link at the bottom of this slide to familiarize yourself with an overview of CMS's Quality Payment Program and the MIPS and also Alternative Payment Model tracks, which are key elements of the Medicare Part B Quality Payment Program. First, the QPP update. CMS is offering a hardship exception for those providers who have never tested to meaningful use, but their situation has changed and now they will participate in MIPS and report on the Advancing Care Information Performance category for 2017. This is a one-time significant hardship exception for 2016 so that no 2018 payment adjustment is made. The eligible professional can never have participated in the EHR Incentive Program prior to 2017 QPP program, and they will be transitioning to MIPS this year in 2017 and will report again on the ACI performance category. This is an application process. That deadline is October 1st of this year, and you must keep all your relevant documentation for this hardship exception for 6 years post-attestation. And this is not to be used for any other hardship reasons previously used for the EHR Incentive Program. This is all by itself in a hardship exception application. There are both instructions and the application itself on the CMS website under the 2017 program requirements with the subtitle Payment Adjustments and Hardship Information. And that link is at the last page on the resources. Again, this is an application. It is not automatic. There's also a handy NPI Lookup tool on CMS's QPP site. If you go to qpp.cms.gov, you will see on the right hand of the screen an option to check your participation status. There you will enter your NPI and click on the orange button to check that. From there, you'll see that if the clinician is or is not included in MIPS. In this case, the clinician is included in MIPS, and you can see that in the middle of the screen. Down below, you'll see the clinician summary with their name, NPI, provider type, and the number of associated TINs, and as well as if they were enrolled in the Medicare before January 1st of 17. Underneath that, you'll see the practice summary with the practice name, address, and if the clinician is included in MIPS, if they report individually or as a group. And in this case, they are included in MIPS for both. This is a handy tool we highly recommend for you to use to determine the clinician's eligibility. And if you do see anything erroneous here, you would like to need to update PACOS for that information, because this is coming from PACOS. After you have updated it, it will take a while to be reflected here. The Quality Payment Program does have 4 performance categories, 3 of which will be used in the 2017 performance year. Those are quality, advancing care information, and improvement activities. And the scores from each one of those categories will be added up to come up with a final score. You will be measured against your peers to give you the payment adjustment in 2019 for this 2017 performance year. Today we're going to focus on the Advancing Care Information category. And there you'll see this is weighted at 25% for those MIPS eligible clinicians, or if you are in a MIPS APM, that Advancing Care Information category accounts for 30% of your weight, of your score. So we're going to dive right into the Advancing Care Information requirements. This category is replacing the Medicare EHR Incentive Program, also known as Meaningful Use. In 2017, there are 2 measure set options for reporting. The option you use to submit your data is based on your electronic health record edition. So option 1 is the 2017 Advancing Care Information Transition Objectives and Measures, and option 2 is the Advancing Care Information Objectives and Measures. And so the only difference between these 2 is really that you can only use option 1 if you have the 2014 edition of your certified EHR technology. If you have the others, either 2015 or a combination of 2014 and 2015, you can choose to submit either option 1 or option 2. And we will go over the differences and the weighting differences here in a little bit. So we'll show you what that looks like. But just so you know, you will report either a yes or a no if it's that type of a measure, or a numerator and denominator, as most measures. The reporting period is at least 90 consecutive days, and any period between 90 days and a full calendar. So you could submit data for 121 days, let's say, if you'd like. This has to be a minimum of 90 days, and those submission methods are listed here. There is a submission method of a CMS web interface for groups of 25 or more, and that does require a registration. Those who register for the CMS web interface are the groups of 25 or more using that submission method. So if you have groups less than 25, or if you're using a different submission method other than CMS web interface, you do not need to register at all. That's a common question we get often. So now we'll talk about the scoring categories. Most importantly, you must be using an EHR to submit for the ACI category, and it must be either 2014 or 2015 certified. There are 3 components to the ACI score. The base score, which is made up of required measures, and that would be either 4 measures or 5 measures, depending on the EHR certification of 2014 or 2015, plus the performance score, plus the bonus points. And again, you're reporting either a numerator, denominator, or a yes or no for these measures. Now, you'll be reporting for the required 4 or 5 measures to earn a base score of 50 points. Those are required measures. So you must complete all of those measures to get the base score of 50 points. If you do not complete just one of those 4 or 5 measures, you will score a 0 and not be able to score any additional performance score or bonus points. So failure to meet that base score does give you 0 points, and we'll talk about those measures in a little bit here. Now, from here you'll see that there is, again, the base score, the performance score, and the bonus score, and that the base score is worth 50 points. The performance score is worth a possible 90 points, and the bonus score is worth a possible 15 points. And so we'll talk about those measures here and what makes up the performance and bonus point options. There is an automatic reweighting that is done if you are, for the advancing care information, if you fall into one of these categories. If you are a hospital-based MIPS clinician, meaning that you bill more than 75% of your Medicare charges in place of service 21, 22, or 23, either inpatient, outpatient, or ED, you are considered a hospital-based MIPS clinician. And the hospital-based determination period is anytime from September 1st through August 31st, 2 years prior. Now, these automatic reweighting are done as such. There's no application process, but you can report your advancing care information category, and if you do so, it will be counted just as regular. So the next option for the automatic reweighting is if you are a new clinician to Meaningful Use, the former Meaningful Use program, now the Quality Payment Program ACI category, and that would be those who are physician assistants, nurse practitioners, CNSs, or CRNAs. And lastly, lack of face-to-face patient interaction is also automatically reweighted for this ACI category. So again, this gives you the opportunity to score 100 points total if this automatic reweighting is done. You will not lose out on points if you choose to just let that advancing care information be automatically reweighted to the quality performance category. So all of those 25 percentage points will go to the quality category. So instead of the quality category giving you 60 percentage points, it will now give you 85 percentage points. There is a hardship exception application that is possible, and the application is needed if you have either insufficient interoperability or lack of control over the certified EHR technology, or if you have extreme and uncontrollable circumstances. You will need to submit an application, and that information isn't available right now, but it will be available later this year on the CMS website. Now, as I stated, MIPS-eligible clinicians need to fulfill the requirements of all the base score measures in order to receive the 50 base score points. And if those requirements aren't met, they will get a 0 in the overall advancing care information performance category score. So it's important to note that some of the base score measures can also contribute to the performance measures. I thought this slide is a nice way to show this. Now, this is for those who use the certified EHR technology with the 2014 edition. And so this would be that 2017 base measures for the transition year, that option 1. So first you're going to see the protecting patient health information objective, and that's done through the security risk analysis. This is where you will need a yes or no answer. And so that is required, and there are no performance score points. Next, the e-prescribing, and this is where you will use the drug interaction checks and for the e-prescribing, and the drug formulary for the e-prescribing, and then you'll e-prescribe, and this is required, and there are no performance score points. Next, providing patient access to that's that patient portal, and this is providing education around what the portal is and how it can be used, and how the patients will make a login and how they create their password. So that is also required. Now, if you're using the 2014 edition, you can receive up to 20 percentage points for your performance score by completing this. And this is important to note compared to the 2015 edition, where that would be 10%. And lastly, the fourth required base measure, if using just the 2014 certified version, is sending the summary of care. And that is both required and allows for up to 10 percentage points for that as well. So we will now look at the 2015 edition, and it is very similar except for a couple pieces I want to point out. Instead of 4 measures on the base score, you do have that 5th required base score measure, and that is requesting or accepting the summary of care. So when a patient is transitioned to you, that you would request that summary of care from the primary care provider or other provider or setting of care, or accepting that right into your EHR. So it goes from their EHR to your EHR. And that is required if you use the 2015 edition. Now, in addition, you'll notice that there is up to 10% of the performance score points for providing patient access to information. And remember, with the 14 edition, that was 20%. In addition, if you do request or accept that summary of care, you will get up to 10% in the performance score. So this is a handy table to reference when you're looking at what is required and what can give you the performance score bonus and measures points. The bonus point opportunities are listed here, and you'll see that for the Public Health and Clinical Data Registry reporting, the different measures for the different types of reporting, those provide a 5% bonus and just reporting yes or no. And then in addition, for bonus point opportunities, you can report improvement activities using your certified EHR technology. This is worth 10 percentage points. There are 92 different improvement activities, and we're going to go over those improvement activities and the requirements on our next webinar that Sandy and I will be giving on June 22nd. But I do want to just point out really quickly here, this is a very busy slide, and I apologize for that. But there are, while you can report your improvement activities on your certified EHR technology, there are only 18 activities that you can do that. So just didn't want you thinking all 92 activities can be reported via your certified EHR technology. So you might want to look through this and see if there are possible improvement activities you were thinking about doing, and if so, then think about contacting your vendor and asking if they can report those improvement activities. Now you can see CMS's QPP site. You can take a look at those measures more, and these are just some screenshots of that. If you click on the Explore Measures option in the top right, once you go to QPP.cms.gov, and then you click on Advancing Care Information, it looks like this on the left, and then you scroll down, and then on the right, that's what it looks like, where you will look at the measures, and you can expand those out and read more about those measures. There are two tabs. It defaults to the Advancing Care Information Objectives and Measures, but there's also the 2017 Transition Objectives and Measures next to that. So just want to point that out as well. Okay, I will now turn this over to Sandy, and she'll talk through some details and give us some example of how this scoring works for the Advancing Care Information category.
Well, thank you, Michelle, and I really appreciate the opportunity to discuss the ACI scoring methodology. And I'm really happy to say that scoring for ACI is not quite as complicated as the quality measure scoring that we discussed last month. So moving on to our next slide here. Michelle mentioned the ACI score is the combined total of 3 scores, base, performance, and bonus. You must fulfill the base score before you can pass and move on to the acquired points in the performance category or to get any bonus points. Now, the base score is going to be 50 points, or 50% of the 25% or 30% total final score calculations. If the base score is not met, an eligible clinician will get 0 for the overall ACI performance category. So when you look at the slide, you're looking at the highest numbers you get. So base score, you get 50%. You can get an additional 90% for the performance score, and that's 90 percentage points. And then you can get 15 percentage points for bonus scores. So that calculates to be up to 155% maximum. But CMS is capping this at 100%. So you want to think about that as you're submitting measures. If you're not doing so well in one, but you're doing really well in others, even if you submit some that are lower performers, it may not bring your score down less than 100%. All right, this is a very bold slide. It's kind of like Michelle's measure slide, only this one's on steroids, I guess. She talks through the required measures for the base score. So in order to receive the 50% base score, an eligible clinician or group must submit yes for the security risk assessment measure and at least 1 in the numerator for the numerator-denominator combination of the remaining 3 or 4 base measures, which include e-prescribing, provide patient electronic access, send a summary of care, and if you're using the 2015 the ACI option set, then you will be submitted on the request and accept summary of care. So you have to have at least 1 in your numerator in order to pass for the base score to get 50% and then move on to performance and bonus opportunities. Okay, so now notice on this slide that some of the base score measures can also attribute or contribute toward the performance score, such as the patient electronic access, view, download, and transmit, or the summary of care, and the request and accept summary of care. So not only are you going to get points for those just for being a base score, then you can earn an opportunity to earn performance scores for those particular ones too. So the performance score itself is calculated by using the numerator and denominator submitted for the measure, and then for each measure, then they come up with a percentage score, and that determines a performance rate. So it's a very important point is that, and different from what you are used to in the Meaningful UCHR incentive where you only reported individual data. In MIPS, if you're reporting as a group, for example, you're in an MSSP Track 1 ACO or just doing group reporting for your 10, you will report 1 numerator and denominator for the 10. That is the aggregate sum of all the individual NPIs in that 10. Now, most measures are worth up to a maximum of 10 percentage points, except the transition set has 2 measures worth 20 percentage points. They provide patient electronic access, and then the health information exchange for summary of care. I'm going to go back to that slide where you can see under the performance score category, those 2 particular measures both have you can get up to 20% scoring on those. And we're going to talk about that in an example. That's why I wanted to make sure you notice this. And this is also an opportunity for you to maximize your score a little bit if you want to do especially well on those particular measures. Now, the only performance score that is yes and no is the immunization registry reporting measure. And if you submit yes, then you're going to receive a full 10% bonus points. Now, MIPS eligible clinicians can earn a bonus percentage points by reporting yes or no, yes to 1 or more of the additional public and clinical data registries beyond the immunization registry to receive an additional 5% bonus points. This is all going to make sense to you when you see an example. So by reporting, and also by reporting yes, that you've completed at least 1 specified improvement activity using the CHERT, which Michelle showed you a list of several of those, you're going to receive an additional 10% bonus points. Now, if you look at that table, it shows you the performance rates for each measure is worth up to 10%. So if you would submit a numerator and denominator, and you fell into the 11 to 20 performance rate category, then you would receive 2 percentage points for that particular measure. On this slide, we're going to review a measure example. The base score for Send a Summary of Care measure from the HIE objective requires that you have at least 1 transition of care or referral, and that the MIPS eligible clinician that transitions or refers their patient to another setting of care or healthcare clinician, number 1, creates a summary of care record using their certified EHR, and then electronically exchanges that summary of care. So for the base requirement, you just have to have 1. Now, the performance score for this measure uses the number of transitions of care and referrals during the performance period as the denominator, but the numerator is the number of care and referrals in the denominator where a summary of care was created using CEHRT, and exchange electronically. And the example I'm showing you on the table here on the right is that of 300 for your denominator, or transitions of care and referrals of care, 150 of those you were able to submit, you were able to create a summary of care through this certified EHR, and you electronically submitted it. So you'll submit like 150 over 300 for your numerator. So that sums out to be 50%. And if we go back here, look at the performance rate of 50. Performance rate 41 to 50 is going to give you 5 percentage points for that particular measure under your performance score category. So now that I've probably confused you a little bit, let's try to clarify this by looking at a hypothetical ACI scoring example. In this particular one, I'm using the 2014 Transition Measures and Objectives set. You should notice that just by the columns, we have objective, we have measure, we have reported performance, base score, performance score, and then bonus. So for the first measure, protect patient health information, or the security risk assessment, was this reported? And the answer was yes. This particular example, hypothetical example, this group or this individual did submit that they did do a security risk assessment, and so they receive a pass under the base score. And there's no extra performance points for that, so that's NA are not applicable. For the next measure, electronic prescribing, they did report on that. And they did get 50%. The numerator and denominator came up with 50%. So for the base score, they received a pass. But for the performance score, it was still not applicable. And that's because e-prescribing, if we go back to this slide right here, e-prescribing, there's no additional points for performance score on the e-prescribing measure. That's why you receive not applicable under the performance score. The next measure is the provide patient electronic access, and they did submit that, and they received 50%. That is a base score, so they passed. Because they've submitted it and they received 50%, they fall into the performance rate of 41 to 50, which would be 5 percentage points. But if you note on this example, they actually got under the performance score, they got 10 percentage points. And the reason they did was because this particular one is one that I mentioned before that's worth 20%. So they doubled that 5 percentage points, and they got 10 percentage points. The view, download, and transmit, they did submit, and they were at 1%. This is not a base score requirement, so that just is left negative, left empty, but it is a performance score. And because they got 1%, they fell into the performance rate of 1 percentage point for that. And I won't go through each and every one of those, but we'll go on down to the immunization registry. And they reported yes for the immunization registry, so they received 10 percentage points for that. They did not report any additional registries, so they did not receive any additional points or any bonus points for an additional registry. However, and they did not report any additional practice improvement activities through the CEHRT, so they did not receive any bonus points for that, in that particular category. So let's go ahead and add these up. So the base score, because this is the 2014 Transition Measures and Objectives, they needed to pass the 4 particular measures, which they did pass, so they're going to get 50 points for that. Then we'll add up the performance score, and when you add the total of that column, you have 30. So they have a total of 80 points for their ACI scoring example. Now, this particular example is an individual eligible clinician. It's not an APM, so as an individual MIPS eligible clinician, this is weighted at 25%. So if you take 25% times 80 points, you get a composite score of 20 points for this particular hypothetical ACI scoring example for their score for ACI that's going to be attributed to the final score. Let's talk a little bit about special ACI scoring standards for MIPS APMs. And I will admit to you, I'm trying to wrap my head around this a little bit. CMS just submitted, a couple of days ago, they just released a new informational fact sheet on the MIPS APM. It is called the MIPS APM fact sheet. It's out on the QPP website. I definitely, if you are a MIPS APM entity, I would definitely recommend that you pull up this fact sheet. It has some new information. And in this information, they share that all Medicare Shared Savings Program ACO participants' tax ID numbers, or TINs, must report the MIPS ACI information performance category regardless of whether they meet the QP thresholds or not. So even if you are a QP and you are in a Medicare Shared Savings Plan 2 and you're a QP, you need to submit the ACI. The Medicare Shared Savings Program ACO participant TIN scores for the performance category will be combined as a weighted average based on how many MIPS clinicians are in each TIN. So this will result in one ACO entity group score for the ACI category, performance category, and that's going to apply to all the MIPS clinicians in the ACO. So as it states on this particular slide, the ACO participant TINs will submit directly to MIPS via the MIPS data submission mechanisms. And Michelle talked to you about what the data submission mechanisms were for ACI, and that can be either through attestation through the QPP portal. If you are a TIN that has over 25, you can use the CMS web interface. You can also use a QCDR or a qualified registry or certified EHR technology for submitting ACI. Now, for the next generation ACO model and all other MIPS APMs under the APM scoring standards, MIPS clinicians in the APM report on the advancing care information category through either a group NPI or individual reporting, and that's new. That's more of a clarification. Then CMS is going to score each MIPS eligible clinician in the APM using the highest score for the 10 NPI combination for each MIPS clinician, which may be from an individual or it may be if you do group reporting. The score given to each MIPS clinician will be averaged with the scores of the other clinicians in the APM entity group to produce one APM entity score for the Advancing Care Information Performance category. So the ACI performance category for the 2017 performance period is weighted at 30% for the Medicare Shared Savings Program and the next generation ACO model, MIPS APMs. Now, that was a lot of information. Kind of confusing a little bit, so I really recommend that you pull out that new MIPS APM fact sheet, and it talks about all the categories, but specifically look at the category around ACI reporting. I am going to turn this back over to Michelle because I know she's got some information to share with you also.
Thanks so much, Sandy. That is truly helpful to go through that example for scoring methodology. So Sandy and I put together some tips on how you can not only survive but hopefully thrive in this category. First things first, though, you want to make sure that you are providing high-quality care, and that really will help take care of a lot of these measures. But then, in addition, you want to review those measures that are available and capture that data without interrupting your workflow. Do you have the best workflow for capturing those measures? Documenting the care in the electronic health record as much as possible. Another big point is that you want to appoint someone to routinely extract that data. Now, we've heard some different practices that perhaps they may even have issues with extracting the data from their EHR vendor. So If you do not know and are not able to extract that data by yourself, please reach out to your vendor immediately to see if there's something that you need to learn how to do, or if that's available, or when their timeline will be to be able to extract that data. Hopefully you are able to do that, and you are monitoring and tracking it. And by doing so, hopefully as well that you will share that with the clinicians and staff often, because if one provider, one clinician is scoring very well and another clinician not so much, then maybe they need to share their workflow with each other and make everyone aware. And then if you're routinely extracting that data, you can watch for those improvements and report those out to everybody. It really does help in understanding where you are at the baseline and where you would like to go, and maybe set those goals and share the progress towards those goals. And then finally, know how you want to submit your data to CMS. Find that out in the beginning so that you understand the whole practice, understands how you're going to submit that. Are you going to submit it, as Sandy said, via the portal or the QCDR, qualified registry, directly from your EHR if they're able to do so, or if you have a group of 25 or more through the CMS registry web interface. So really some considerations include the time and the cost to submit for each one of those. They do vary, and also the capability of the EHR to do so. Now, we also came up with some tips, and first of all, you want to check that your electronic health record is certified by ONC certifying body, and if it is, then it will be ready to capture the information for the ACI category and certain measures for the quality category as well. But if you find out that your EHR is 2014 certified, make sure that you are in line to get your 2015 certified EHR technology as soon as possible. The reason why I say this is historically we found that it takes vendors longer to get their certification than maybe they planned, and that pushes back the implementation of your implementation of the certified EHR technology. So if you're on that list to get the update, you've paid your maintenance fees or whatever might be due, then hopefully you will get that before it is required in 2018. Next, if you really look at understanding the scoring methodology and how to maximize your score, look at those gaps and where you could maybe be performing better, or maybe, some clinicians are not performing as well as others, and how we can maximize that score. And next up, you want to utilize your high-functioning EHR for every possible process. So remember, your vendor for your electronic health record really is your partner. And if you don't have an established relationship with a contact there, we really do recommend that you try to do so, because not only will you be able to get in line for your 2015 upgrade, but also to understand the workflows and maybe help you through a process if they can provide manuals for your EHR technology or direct you to the best place to go, so you can use that EHR to the best of its ability. And then finally, adopting patient-centric workflows. This really, if you stress the preventative care with patients and that high-quality care, this will help with these patient-centric workflows. Those might include daily team huddles and talking about who's going to be in for the day and what needs to be done for that patient before they come in, so everyone is aware. And then all clinicians and staff, please continue to suggest that patient portal for every type of use. So you have higher scores for the many different measures, whether it's patient access to the information or the health information exchange, or view, downloading, and translating. The patient actually goes out and uses that portal to look at their data. Secure messaging for the staff to send messages to the patient, and for the patient to send emails to the staff through the secure options of that portal, and also sending the patient education to the patient through that portal. It just gives them a reason to go out there and log on and use it and become familiar with it. And so there's lots of options there that if you stress the patient portal, then you can definitely maximize your score that way. Now, we talked a lot about the transitions of care, both Sandy, the example, and then as well as the scoring possibilities, both for your base score, but also for your performance score. And so we have some tips here for the transitions of care. And first of all, you want to make sure you implement easy-to-understand strategies to improve your transitions of care and your referrals. So, number one, understand how to document both the sending and receiving or incorporating a summary of care in your EHR. This isn't something that you've probably been used to doing, and so you want to work on the workflow for that. Who will be sending it? Who will be taking care of those summaries of care coming in? Maybe you want to have a group of individuals rather than one person in case that person's out on vacation or sick for the day. Really understanding who will be taking care of those summaries of care, which group. And then making sure you identify that, and maybe a backup as well. All good ideas to understand how to make sure they understand the summaries of care workflow. And then using your EHR to share your patient data efficiently. So number one, you want to find out your direct address for your EHR, and that is basically that secure email within your EHR from which you will send and receive those summaries of care. And many times what we're finding is that practices don't know what you're talking about when you say that you need their direct address or email address from within their EHR. So it's going to take some time. And we recommend reaching out to your vendor, number one, to understand what your direct address is if you don't know. And then next, reach out to those providers who refer to you and who you refer patients to in other settings, maybe hospitals, for instance. Find out their direct address. Like I said, many times they do not know what that is, and so if you start now with that process, collecting those direct addresses and entering those into your electronic health record, it will make it so much easier for sending those summaries of care and receiving or requesting those, and your scores then will be even maximized more. So again, if you work through your workflow on how this will work and you have your direct address, we suggest also sending a test patient summary of care for that patient after the clinic that you receive their direct address from, and that way you can test to make sure you understand how that process works, and they can also test to see what it looks like when it comes in and how to use that summary of care to incorporate that data into their electronic health record. So it's really a big piece of this advancing care information category, and so we recommend going through that in great detail. And please, again, reach out to Sandy or myself if you have any questions or don't understand what we might be talking about, or your vendor. We can help direct you to the correct verbiage to ask your vendor as well. Now we want to give you some assistance and resources CMS has really tried to make a one-stop shop for assistance with this quality payment program, and it does not matter if you're a solo practitioner or if you're in an ACO. There's help in all realms, and so this help is free. And we'll start by looking at this graph. I really like this graph. When you review it, you'll see it is a little bit of small text, but you can at least see the different options here. In the lower right corner, we have technical support, and this is through CMS. So they have an excellent website. We recommend going out there and taking a look at those tips to get started. Program basics, tons of informational sheets, webinar recordings to review. It's just an incredible site. That's where you go to check your NPI to see if you're eligible. And also there are advanced alternative payment model learning networks there as well. So just great information at the CMS QPP website. Then if we go in the upper right, the small and solo practices, this is the area that I work in for those with 15 or fewer clinicians, and we provide help through they call it the SURS, or Small Underserved Rural Support. And so there are organizations around the country to help you, and we can help direct you to the appropriate organization if it is not through Telligent. And then in the lower right, those large practices of 16 or more clinicians or those within ACOs, that would be, your help would come from people like Sandy in the Quinn QIO. And again, there are Quinn QIOs across the country to help you with this and really provide excellent service. And then finally, but certainly not least, in the upper left corner, this is the Transforming Clinical Practice Initiative, or TCPI, and this provides more hand-holding, one-on-one assistance, and as well as helping you transform your practice. And so this is another great area of assistance for you, and we can help you determine what might be best for you and your practice by giving either Sandy or myself a call. Now, we would just want to reiterate in summary that we're all part of this quality payment program. We all have different roles, and we know that the value-based payments have arrived, but if you think about the way the incentive program is designed, it's designed to tie payment to quality and encourage more effective coordination and integration of care. And I think we've really hit on that with our tips as well as the scoring and how that works. But we want to reiterate that whether you're a payer or CMS or clinicians, care teams, or you or me, patients or families, we're all here to have achieve these transformational goals of quality through this quality payment program. And we all share a similar goal to improve those patient outcomes. Now here we have a couple different upcoming learning opportunities. Number one, we have the QPP Coffee Talks with Telegen QIO Quality Advisors. And this is a monthly coffee talk, and it really is a way to talk about issues or questions that you might have. The next one coming up is Thursday, June 8th at 11 a.m. Central Standard Time. And there's a link to register here. And then next, the MIPS Survive and Thrive, the improvement activities and costs. Sandy and I will be giving a webinar on June 22nd, and this webinar will go from 12 until 1 p.m. Central Standard Time, and there's a link to register here as well. Here is a list of the CMS resources you will see on the CMS QPP website. There are lists of the objectives and measures as well as different ACI categories, fact sheets, and then also I put a link here for the hardship exception that I talked about, the 2017 EP transitioning to MIPS hardship, and it's a link for the instructions and the application. Well, we want to thank you for joining us today. We really appreciate your time, and we have both the contact information for Sandy as well as for myself. Please give us a call. We'd love to work with you and answer any questions that you might have. And in the meantime, we hope you have a great day. Thank you so much.